Okay, one more.
Now we're going live. It's loading. Okay, we're live.
We're live.
No.
Hello, everyone. My name is Erin O'Donnell. Greetings from the House Institute Foundation, and thank you for joining us for our live Ask Me Anything event. Today, on this rainy day in LA, we are celebrating World Hearing Day. This year's theme is Hearing Care for All. World Hearing Day is an annual global campaign spearheaded by the World Health Organization, and this year is very special because it marks the launch of the very first World Report on Hearing. In honor of this, 200 launch activities across 60 countries are taking place today. It is being called the 24-hour Hearathon, and this event is part of that. The World Report on Hearing is a 252-page document that was released today, and it provides guidance and evidence-based practices for how to integrate people-centered hearing care and ear care within the healthcare systems to increase access to care and to provide universal coverage. How we can act on to prevent hearing loss, how we can act to identify hearing loss, and how we can act together to address hearing loss are some of the key themes that it covers. This critical document has been a collaborative effort for 3 years in the making, and this morning, at its launch in Geneva, panelists from around the world shared their inspiring stories. The Minister of Health in India shared how he and his country plans to integrate hearing care into their primary healthcare system and to combat widespread underrepresentation of hearing care there. From here in the United States, Catherine Bouton with the Hearing Loss Association of America shared how she experienced sudden hearing loss in one of her ears and waited 22 years before getting a hearing aid because of fear for the potential repercussions hearing loss would have for her career in journalism, as well as the grief that comes with losing one of your senses and coming to terms with this. And Catherine's story is not entirely unique. On average, people wait 6 to 7 years beyond when they first need hearing aids to actually obtain them. And there are many reasons for this, of course, but stigma is one of them. We need to reduce the negative connotations and stereotypes often associated with hearing loss, which can serve as a mental and social barrier to receiving care. So what can you do as members of the public to help? Well, share your stories, wear your hearing aids and cochlear implants proudly, spread awareness, reduce stigma, promote safe listening practices. Today, 1.1 billion children, for example, are at risk of damaging their hearing due to unsafe listening. Other ways to help is through financially supporting important efforts, such as the work we do here at the Health Institute Foundation, where we focus on ear and hearing research, education, and global health, so all may hear. Our research paves the way forward for improvements in hearing treatments and interventions and has done so since 1946, and we continue this important work today thanks to the generous support of donors such as yourselves. Other tangible ways to support our education efforts, including sponsoring the distribution of a go-to educational resource, our temporal bone surgical dissection manual. This is being distributed across the world from the Philippines to Kuwait, and $25 will help cover the international shipping costs in a very tangible way to ensure that hearing professionals there can learn with this resource and provide better hearing care to their patients. So thank you so much for joining us. Without further ado, we will go over to the main event with Dr. John House. Thank you so much for being here and for answering the questions that many of our followers and people of the general public have around hearing care.
Thank you, Erin. Unfortunately, Dr. Peng will be here in a minute to help me, but let me go ahead and get started. I was interested in your comments about hearing aids and the stigma about them, but I'm going to tell you a little brief story. President Reagan was one of my patients, and during his first term, he came to see me, and we were discussing some of the issues he was having with his hearing, because his right ear had been injured by an actor firing a gun close to his ear. And so it was obvious that he was having trouble in certain situations. And so I said, after my examination and evaluation and reviewing his hearing test with him, I suggested, Mr. President, I think what you need is a hearing aid. Now, I fully expected to get this stigmata. He was going to run for re-election, There were certainly questions about whether or not it would make him look old, because age was an issue at that time. And he said, "Oh, you think it'll help?" And I said, "Yes." And he said, "Okay, let's do it." And that was it. He got a hearing aid. It took the press about 2 weeks to finally see it. When they finally saw that he had a hearing aid sales went up 75%. So just a story that it is really something that people should consider if they're having any issues. And many of my older patients will say, "But it'll make me look old." And I say, "Well, when you go around going, what? That makes you look old too." So we have some interesting questions here that I'd like to kind of review. In fact, one of them is right here. It says, "Are there any early signs of hearing loss that I should look out for?" And I just put in here, when your family starts to complain that you're asking to repeat, I think that's one indication. Obviously, if you have ringing in your ears, if you find that, for example, you don't hear as well on the telephone, particularly if it's just on one ear, you have to switch the phone over, you should have an evaluation. And an evaluation involves basically a complete audiogram, and an audiogram is performed typically by a doctor of audiology, and we test the pure tones, and we ask also to be able to see if they can understand a list of words which are presented, and so we call that the discrimination. Now, of course, the next question comes up, and that is, well, what do you do about it? Well, it depends, and that's why a medical examination is important initially, to see whether there's number one, a treatable cause. For example, would they be a candidate for surgery? Sometimes hearing loss can be as simple as just having too much wax in the ear, and then removing the wax will help the problem. And sometimes we can just say, well, this is due to excessive noise exposure, or it's due to the normal process of aging, in which case hearing aids can be quite beneficial. There was a question here about hearing aids, and for example, if someone obtains a hearing aid from an outside vendor and they want us to check it, for example, such as Costco, can we actually evaluate that hearing aid and adjust it? Well, in the case of Costco, no, we cannot, because they have proprietary programming of their hearing aids. But most hearing aids that are not purchased from Costco can be checked and adjusted and refined. Another question about hearing aids came up was, how often should they be replaced? And again, that depends. It depends first of all on the person's hearing. So if the person, for example, if their hearing is exactly the same year after year, which many times it will stabilize and people don't continue to go on for further hearing loss, or but if they don't, so it doesn't change. What I'm saying is, more than likely, that doesn't necessarily have to be upgraded every few years. Having said that, there is new technology. As you know, I mean, an example is a computer. You think you got the latest, greatest. In 3 or 4 years, there's a better one. And so, and there are some fabulous advances in hearing aids, I would say, in the last 5 years. So if someone has a hearing aid that's more than 5 or 6 years old, I certainly would come in and be evaluated to see whether it's better. I always tell my patients who are getting or looking into the possibility of upgrading, is there is a trial period. So they can use the hearing aid, purchase the hearing aids, use them for a month, get a chance to see whether they are significantly better than their old hearing aids. If there's not much difference, they don't need to keep the hearing aids. On the other hand, if they find there's an advantage and they're working better, then certainly we would recommend that they keep them. And then also the advantage of that is they now have a spare set. So if something happens to their new hearing aid, they can go back and use the old hearing aid while it's being repaired. How often should, these are things about upgrade of the hearing aid. And someone also asked about the Baha Ponto, how often should that be upgraded? And let me explain a little bit about what a Baha is. It stands for Bone Anchored Hearing Appliance, or Bone Anchored Hearing Aid. And this is something that we implant a post or a attachment onto the bone, and then on the external there's a device that actually vibrates the bone, and that sends the hearing directly to the inner ear. And we do this in cases where the person, for example, has a unilateral hearing loss. So we can put it on one side, it'll transmit the sound to the other side. Or someone, for example, has the ear canals are completely blocked with either they're born this way or they've had disease which doesn't allow them to use a standard hearing aid. A bone-anchored hearing aid can work very well. And as far as how often it should be updated, well, again, just like hearing aids, there are always new advances. So someone could certainly consider upgrading their hearing, their Ponto, when the audiologist feels that there's something that would be an improvement. And I see Dr. Peng has just finished his clinic, and so he's going to step in here also and answer some of these questions.
Right. Please be gentle.
So we'll take a brief break for Dr. Peng. Dr. Kevin Peng is one of my esteemed associates. He's been here, how long have you been here now?
5 years with the clinic.
5 years. Okay. Well, he's doing a great job. We love having him here. You know, at the House Ear Clinic and Institute, we do train young physicians and have fellows, and we were lucky enough to have Dr. Peng come and do a fellowship, 2-year fellowship, and he was so good we asked him to stay.
It was my honor.
Okay, why don't you take one of the questions?
Great.
You have the list there? Or
Yeah.
You want me to? Okay.
Randy, I'm just going to start my other live video here.
Cool.
I'm gonna, but I don't think, sure, I'll take a peek at the list first, actually.
There you go.
Randy, can I give this to you to prop up somewhere? with that?
Yes.
Thanks. And,
We'll put that in between us.
yeah. Which question are we on?
Well, I'm having going down. I've been skipping around. Here's a good one for you to answer right there.
Are they working on a hearing nerve transplant? No, it's remarkably difficult. I think one of the things that's difficult is what we call the tonotopic organization, which is a special way that the hearing nerve and the cochlea, that part of our inner ear that senses sound, is organized. And then so the high frequencies go from one part of the cochlea all the way to a specific nerve fiber, and that goes to a specific part of the brain. So it's really difficult to hook up the nerves really in that microscopic arrangement and make it work the way we expect it to. Not to mention we'd have to expect the body to then regenerate the connections between the nerve that we're, the nerve that's in the body and the nerve that we're putting in there. So it's unfortunately a lot of moving parts. So I don't think the transplant is in the future.
Well, no, and I think what you're saying is correct. There have been studies in
I'm
trying
sorry
to
to
read.
interrupt. What's the question on this one?
Oh,
So
it's are
this
they
is-
working on a hearing nerve transplant?
Okay, thanks.
Okay, and rather than talk about the nerve itself, we're talking about the hair cells.
Yes.
And those are the little nerve endings that actually will, when they're stimulated by the motion of fluid, they will cause an electrical impulse to go and then attach or to transfer to the nerve itself. And so there have been a few studies using stem cells,
Yes.
you know, to like in Kansas, and a few patients. But the problem is, as Dr. Peng was saying, it's one thing to have the hair cells, but you also have to have the connections.
Right.
And so if you got hair cells that are working, but they're not sending it anywhere, it's not gonna help.
Yeah. No, that's
You
true.
might mention a little bit about the Cochlear implant, because I think that would be a kind of a segue
Yeah.
into another way of restoring hearing in people who do not have nerve function.
And
You gonna
so,
talk about that?
sure. Yeah.
I have that over here if you wanted to show.
Sure. So this is a nice demo unit that we have, and it shows a cochlear implant. This is the external processor that we're looking at here. There's a portion that hooks over the ear, and also a portion that connects to the coil, the part inside underneath the scalp that we put in at the time of surgery. More and more, the cochlear implant companies in the United States, there are 3 of them. There's one called Cochlear, there's one called Advanced Bionics, and there's one called Medel. More and more the companies are coming out with processors that actually don't have the behind the ear portion, but instead they only have a magnetic portion that again links up to the part that we implant at the time of surgery. And over here, it's sort of hard to see in this, but we have a little cross-section of the implant that we actually do put in at the time of surgery. And that's in the scalp behind the ear, and we put it in through an incision behind the ear. Now, cochlear implants such as these are saved for patients who have profound hearing loss. So hearing loss where hearing aids really aren't working at all. And sometimes we do it in patients with hearing loss in just one ear, profound hearing loss in one ear. Traditionally, we used these implants for patients with hearing loss in both ears.
And that's been a great advance. It's been something that was first developed here at the House Ear Institute and House Clinic back by William House, my uncle, in about 1970. He actually started his work in 1960, but really got it started in 1970.
Mm-hmm.
And it was a long, long, difficult road to actually, number one, develop it, but also to get it accepted,
Right.
especially from the professional community thought that it wouldn't work, but in fact it has worked very nicely.
I'm going to put myself and Dr. House on my live video here so that we also have another. Maybe I'll rest it over near you, Randy. Would that be okay?
Yeah, of course.
I'll put it over here.
We also have some live questions coming in. If you all, I don't know how you want to do the order, but
Great.
yeah,
We can do a live one perhaps, and then
Yeah.
a few live ones.
Yeah, sure, sounds good. Aaron, do you wanna ask the? Or I guess it looks like I got one here. It's it has to do with tinnitus.
Mm-hmm.
It's from a sound engineer. The question is.
So this sound engineer is asking what he can do with tinnitus, as he's worried about his future as a sound engineer and if his hearing will be damaged for the rest of his life.
You want to take part
Sure.
of that question?
Yeah. So I think the first thing would be to diagnose any hearing loss if there's any present. So I would say to the person posing the question, make sure that we have some sort of hearing test available. There are lots of hearing tests that we can even perform on even our smartphones, apps that you can download that are free, and that'll show you your hearing level. And you can certainly talk to your local audiologist or ENT otolaryngologist about the results. The second is, I think what the person asking the question is getting at is that tinnitus, or ringing in the ears, is indeed associated with hearing loss. So sometimes if somebody starts noticing a new sound in their ears that they haven't heard before, that's associated with the fact that they've suffered a loss in their hearing. Hearing losses can be treatable, but sometimes if a patient has had hearing loss over the course of many years, it can be permanent. It's difficult, though, still to predict what one's hearing is going to be in the future. I would say the vast majority of patients, even ones that currently have hearing loss and with tinnitus, most of those patients won't go on to develop deafness or profound hearing loss. But it can be difficult to predict which patients proceed on to having that sort of hearing loss.
I'll make a few comments. I'd like to emphasize, number one, that tinnitus is not a disease. Tinnitus is a symptom, and typically of a hearing loss, as you mentioned. In fact, 80% of patients with hearing loss have associated tinnitus.
Mm-hmm.
In my experience, about 5% of my tinnitus patients actually have normal hearing, so it can happen in normal hearing.
Right.
And tinnitus is generated in the brain, so it doesn't matter what we do to the ear itself, that the tinnitus is coming from the brain, and it's coming from an area close to the limbic system. So that's why stress, tension, depression, fatigue, anything like that will aggravate the tinnitus.
Right.
And of course there was a question here about the treatment of it. Well, first of all, it depends on the cause. And you mentioned you're going to get a hearing test. I think you need a medical evaluation.
Mm-hmm. Absolutely.
In some cases we have to do MRIs to see whether there's something that's pressing on the nerve. But the tinnitus, and then once we find out the cause, and it may just be something simple as just age-related hearing loss, or sound engineers, of course, are always concerned about being exposed to too much loud noise.
Definitely, yeah.
So you want to eliminate that factor. And then as far as treatment, sometimes hearing aids can be very helpful if there's a hearing loss.
Right.
Sometimes retraining the brain not to hear the tinnitus. Tinnitus may still be there, but you learn to ignore it. That's called tinnitus retraining, and that's a therapy that can be effective.
Mm-hmm.
Patients who have a great deal of anxiety associated with something like biofeedback can be helpful. Or in some cases, medications which can be prescribed. So it's not just a simple answer that here's what it is and this is what we can do for it.
That's
because
right.
we have to do a lot of evaluations first.
Yeah. Shall we do another live question, Randy? Or
Yes, please. Aaron, you mind asking it?
Sure. So Dana M asks what ANSD looks like in children.
So auditory neuropathy spectrum disorder, or ANSD, is typically a condition where patients can actually have varying degrees of hearing loss, but often it starts out when the child is born, so it's congenital, it's from birth. And what it looks like is it's a very specific pattern on hearing testing. So typically we require that there's a test called OAEs, or otoacoustic emissions. That's one of the very commonly performed tests for newborn hearing screening. Those results have to be normal, but usually the auditory brainstem response test, or the ABR test, which is a nerve test, has to be abnormal. So it's that combination of factors. The child has a hearing loss, the child has normal OAEs, and there are also abnormal responses on the ABR testing. Those would lead to a diagnosis of ANSD. That being said, I think it's a wide spectrum. I think there are patients with ANSD that have profound hearing loss. Occasionally we'll suggest that those patients undergo surgery such as a cochlear implant, as we had just discussed. And other times, patients with ANSD can either wear hearing aids or even continue with their lives unaided without wearing any additional amplification.
Clarify one thing is, as far as I know, it has to do with the synaptics, the synapses, the connection between the nerve, the hair cell, and the nerve itself.
Right.
So therefore, they may have normal hair cell function.
That's right.
What you said, right?
That's right.
And but they have no discrimination.
That's right.
And so it's very frustrating problems. I think what you're saying also that maybe a cochlear implant would be helpful.
That's right. Sometimes,
But in
severe
selected cases.
yes, and sometimes the results are great, and sometimes they're not as good.
Yeah, it's a very unusual problem, by the way.
That is very true.
Very rare do we see it. There's a question about earwax. How do you deal with earwax, Kevin?
Well, I know sometimes the publications will say don't put anything in your ears. I generally agree with that. I think baby oil is pretty harmless, and sometimes I'll have patients even just put in baby oil in their ears to soften the earwax on a regular basis, like once or twice a month. As long as somebody has a normal tympanic membrane, normal eardrum, without a hole, baby oil won't do any harm, and it can soften the earwax, and with the moisture and water of a shower, that can help the earwax come out. But I want to emphasize that for most people, your ears will clean themselves, meaning you don't have to, in general, do anything special to try to pick it out or pluck it out.
What do you recommend about Q-tips?
Yes.
Get in there and really clean it up? No?
Nothing smaller than your elbow in your ear.
Yeah, so we
That's
definitely do not like Q-tips, because especially when the patient comes in who's been using them, they pack that wax right down there, all the way down to the eardrum, and it's very difficult to get it out.
Yeah.
But having said that, there are kits that you can get in the drugstore.
Yeah.
Debrox makes one that you can use some drops and rinse out the ear once a month or so. You don't want to do it too often.
No.
But again, having said that, we have patients who have to come in on a regular basis because they have such a huge production of wax, and they just have to be removed manually using a microscope and micro instruments.
Yeah.
Another question?
We have a couple more questions live.
Mm-hmm.
What can cause the upper outside of the ear to get red and very swollen?
You take that one.
Yeah, so there are a few causes. I think one of the first thing we think of is maybe an infection. We call it either auricular perichondritis or auricular chondritis, like an infection or some swelling, inflammation of the ear itself. It also depends on the age of the patient. For example, we know that older males are predisposed to having issues, particularly with the cartilage of the ear, because the cartilage of the ear gets harder as we get older, and it also tends to be harder in males. So the first thing to figure out is if it's an infection, and I think an ENT or even a primary doctor would be able to help you with that. The things we look for an infection are the presence of pus, if there's pus coming out of the ear, if there's any other symptoms like fever. And the second is how long it's been going on for. If it's an infection that's been going on for a week, that's managed differently. than than the redness of the ear or swelling that's been sort of on and off for a few months, say. And I do want to say that actually for some patients with ear issues, changing a pillow helps. Because sometimes the configuration of the pillow or the hardness of the pillow can lead to significant irritation, particularly for patients who are side sleepers or patients that turn their head when they're sleeping.
What about polychondritis?
So that's also a rare condition. Like relapsing polychondritis is a condition where patients can have swelling that occurs over and over again of the ears, and typically we think that's some sort of rheumatologic or autoimmune issue.
Right. And they're treated with steroids.
Right.
Periodically. Yeah. Yeah, that's very uncommon, like you said, but I've seen it enough that
Sure.
that
That's
it's-
something to consider.
can be a frustrating problem too.
I think I have a good one here. It might be a tough one, but we'll see how you do.
Tough one.
Yeah, it says, I read about frequency therapeutics medicine for severe hearing loss and tinnitus. I was deafened 40 years ago. Will it help me regain hearing? I have a 22-channel implant in one ear. So frequency therapeutics medicine, is that something you're familiar with?
I'm not
I'm not
familiar with it,
familiar.
Kevin.
No, I'm not familiar with the company. I think I have an inkling of what it is, but I do not know the specific therapy that we're referring to there.
Okay. No worries.
I will say that so far, hair cell regeneration and stem cell treatment has not, to my knowledge, reached really prime time clinical use. We do rely heavily on cochlear implants, such as the one that was described in the question, for restoring hearing, or at least helping with hearing, in patients in those situations. But I know there are lots of trials going on, and it's certainly possible that in the future, even patients who have previously undergone cochlear implants could potentially be a candidate for such therapies, such as either stem cell therapy or hair cell regeneration.
Well, also, he mentioned that this person has a implant in one ear, and depending on the other ear, certainly an implant on that ear too, because and that's something when we first started doing implants. We were only doing one ear for several reasons. One is insurance, but also just because we didn't know it would be that much better. And it turns out that yes, just like hearing aids, both ears are important. If we can help both ears with hearing aids or with implants on both sides, the patient will get much better spatial hearing, directional hearing, and do a little bit better in background noise. Here's a question here about eustachian tube issues, and I'll read the question because it's a little complex here. What are my treatment options for a person with eustachian tube dysfunction accompanied with inflamed dry sinuses, often other than nasal steroids? Kevin, you want to discuss that?
I think one of the things that stood out to me when I read this question was that we need to make sure that the patient is seeing an otolaryngologist who's really able to address the sinuses first. We really want to make sure that the sinuses are in tip-top condition. So sometimes that means nasal irrigation. Sometimes we add steroids to that irrigation to make sure that the sinuses are getting all of the anti-inflammatory, anti-swelling treatment that they need. And then beyond that, if a patient still has eustachian tube dysfunction, like popping ears, clogged ears, inability to pop one's ears, then we think about doing a eustachian tube balloon dilation. That's really only come on the market over the past couple of years in terms of formal FDA approval. And there are a couple of companies that make eustachian tube balloons, and the point of the balloon is to physically dilate the opening of the eustachian tube from the nose side of things. Again, the eustachian tube goes from the nose to the ear, and the thought is that if we can dilate the opening in the nose, then more air is going to get into the ear, and overall make the eardrum ear work a little bit better. But I think what's really important is, to make sure that the inflamed dry sinuses are managed. Because if somebody has a lot of sinusitis, or as we say in ENT, like chronic rhinosinusitis, where the sinuses are inflamed, the nose and the nasal passages are inflamed, then those patients have a much harder time fixing their eustachian tube issues without fixing their nose issues first.
It all mentioned allergy evaluation. Dr. Dearberry at the House Ear Clinic specializes in allergies and how that affects the ear. And many times patients who have allergies, they may not even be aware that they are being affected so much by it. But to get tested to find out what they're sensitive to, it could be pollens or dust, or sometimes foods
Right.
can trigger these problems. So those are things that if that is part of the etiology, many times desensitization solves the problem.
Right. Absolutely.
I have to take the next question though, because it says, what's an approximate volume to listen to music in headphones so I don't damage my ears? That's funny. Well, the only reason it's funny is because I finally came into the 21st century. I got myself some AirPods, and when I'm getting them paired to my phone, it says, now, do you want to be able to set the volume so you won't cause yourself to have a hearing loss? I thought that was great.
Yeah.
I will mention a couple of things. The two most common causes of nerve type hearing loss is age, which is obviously significant. As people age, a significant percentage of patients will develop some form of hearing loss. But the other is excessive noise exposure. And we see that, of course, we see that in the military. We saw a lot of that during World War II in Korea. And when I served my time in the military, I was working with helicopter pilots, and the noise without adequate ear protection was a problem. And a rule of thumb, by the way, and people say, well, how loud is too loud? If you can carry on a conversation like we are, that's fine. If, on the other hand, it's so loud out in our environment that I have to shout at you, get over close to you, then that's too loud.
Right.
So one has to wear ear protection or not be in that environment.
Right.
But as far as it should be a comfortable level, and that's my answer. Sometimes we used to say to the parents, if you can hear it, and your kid's wearing his earphones, if you can hear it, it's probably too loud.
Right. I think another thing I'd like to tell, I guess parents in particular, because often it's something that parents will ask us about their children is, if their children are listening to something on their headphones, if the parent's talking to them, the kid should at least be able to realize that they're being spoken to. And I think that's also a good, very rough estimate of how loud or how soft the music or the gaming should be.
We have some more questions from our live audience. What is the result of getting hit or punched on the ear?
Well, the one thing we see is if a person gets slapped on the ear, it can puncture their eardrum.
Right.
And interesting enough, though, that usually heals.
Yeah.
So it's unusual that it won't heal on its own. But patients come in sometimes at the house clinic. We'll put a little paper patch on the eardrum where the hole is, so that the eardrum can heal underneath, and use the patch as a scalpel to allow it to heal.
I think something else that can happen is patients can suffer a temporary hearing loss, because if the pressure is enough to rupture the eardrum, or even if it doesn't rupture the eardrum, that's actually transmitting a lot of pressure waves into the ear system, so into the eardrum, into the hearing bones, into the inner ear. And some of those patients may have a temporary hearing loss just from being hit on the side of the head, on the ear. And in very severe cases, that can also lead to some temporary dizziness, because the ear controls both sound and balance.
Well, that's certainly true, especially if someone's had a fracture
Right.
of the temporal bone.
That too, yes. Sure.
And that, of course, that's not more than just getting hit on the ear. That's a major trauma.
That's right.
And then that'll fracture right through the inner ear, or it'll fracture to the point where it dislocates the little ear bones.
Right.
So these are things we see at the house clinic, and not too, fairly often.
Yeah. And so if that happens, I think I would want to emphasize to our viewers that one should seek medical attention soon, within 24 hours, 48 hours. And if the person feels like their hearing is impacted, then definitely get an audiogram. So a formal hearing test to really see what the levels are, and talk to an audiologist or an ENT doctor about it.
What treatments are available for tinnitus?
Well, we talked a little bit about that. I think
we talked about the sound therapy, which is
okay.
Yeah.
So
and then we talked about tinnitus retraining therapy, or TRT. Sometimes we'll have patients just undergo cognitive behavioral therapy with the help of a psychologist, and TRT takes that a step farther, almost integrating the sounds with that course of treatment. I think that those are some of the most effective options. Unfortunately, no medications have consistently shown to be of benefit, nor any supplements. So often I don't recommend, in my personal practice, that patients take any specific medications or supplements for tinnitus.
And of course, you mentioned I did before, if a person has a hearing loss, a hearing aid can be helpful.
That's right.
And there are things called maskers, which are basically like a hearing aid, except it actually makes a more pleasant sound than their internal sound, because people would like to hear the outside sounds better. It's more tolerable. And that's why at night, for example, I recommend sometimes people use some type of device to make sound. On my iPhone, I have a program called White Noise, which puts in all kinds of different choices of sounds that people might like a river running or surf or a fan or some kind of a sound that they find covers up their internal sound and allows them to rest better. You did mention medications. I found a few medications can be helpful in selected cases. In other words, some of that depends on sleep. So I do evaluate the patients and rarely prescribe medication, but there are some medications that can be quite helpful.
Sure.
Another live question. Andrea wants to know what may cause a stabbing pain in the ear without an infection.
So it's the ear has so many nerves going to it actually that there can be a bunch of causes. I think one of the more common culprits that is underappreciated is jaw pain or jaw issues.
Temporal
Dr. House, exactly.
TMJ.
It's right in front of the ear. Our jaw joint is right in front of our ear hole or our external auditory canal. And I think that's probably the number one cause of pain that's not related to infections. Either some temporary muscle tension in the joint that's a little bit off, or even some inflammation in the joint where the joint is a little swollen and it's not functioning properly. And I think that's something that they discuss certainly with a dental specialist or an oral maxillofacial specialist, whether or not there are treatments available for that.
The first question I ask the patient is, do you grind your teeth at night? And sure they do. And sure enough, we do the examination, and we can see that the muscles are very tense and tender. And I like to say that the jaw joint is actually part of the ear canal. In other words, that whole front of the ear canal is related to the joint.
Right.
So it's very common. I'd say that's probably the most common cause, other than obviously if there's an infection, that's easy. But
and I think much farther down the list as a number two is much less frequently is like some sort of nerve pain, some sort of nerve getting irritated, some sort of nerve going to the ear. There are probably about 4 or so nerves going to the ear. Any of those nerves, if there's some irritation along that nerve pathway, that can cause some ear pain.
You mentioned that Arnold's nerve, for example.
Yeah.
So actually, someone can have a problem in their throat and have ear pain.
Yeah, Jacobson's nerve, the glossopharyngeal nerve.
Problem in their throat is referred pain, it's called.
Right.
Well, I know you both have patients to see, so feel free to let us know when you'd like to end. But we do have like a few more here,
let's
maybe.
let's do the live questions. I think those are great.
Okay, awesome.
So we have a few live questions on cochlear implants.
Okay.
So maybe you can ask a few of them together. Arlene would like to know what cochlear implant surgery looks like. And there's also a question around how the balance test is administered for evaluation of CIs.
Sure. So I think this is a great plug for our YouTube channel where we have a lot of videos of surgeries. But if you want to see cochlear implant surgery, that's where I would go. I'd go on YouTube and look at one of our videos or look at some of the other videos that have been published. And I've looked, and there are actually some great videos out there.
But to answer the question, I think it's important to understand that the surgery involved is done under general anesthesia. We make an incision behind the ear. It takes probably an hour to an hour and a half to do the actual surgery part. And electrodes are then inserted very carefully into the inner ear. And then when the patient's when we suture up the incision, then we test the electrodes electrically to be sure that they are all functioning.
That's right.
So the whole process is done as an outpatient procedure. And I always like to say that's the least, it's the most complicated part of the procedure, but the audiologist then has a lot of time working to get the implants properly tuned.
Right.
So it's a team effort.
Regarding the balance testing, usually we performed a standard balance battery. Sometimes we'll call it video nystagmography, or VNG for short. Other times, we just call it balance testing. And that will involve a bunch of tests where the patient is wearing some infrared goggles. So the goggles look dark on the inside, but they have a little infrared light, and we're recording the eye movements under infrared light. and we'll often put hot and cold water into the patient's ears to really test their balance function, because hot and cold water surprisingly stimulate our balance system, and they make the patient dizzy, and we measure that by looking at their eyes. So we do that as part of cochlear implant evaluations, especially for patients that are over 65 years of age, or if patients have dizziness that they tell us is really bothersome. But we don't necessarily perform it as a matter of routine, perhaps for patients that are under 65 years of age.
I think one of the reasons, I think, Kevin, we do, and when you would agree that we do this, because if we are concerned the patient has one side that the balance is not so good,
Mm-hmm.
and they're really relying on the other side for their balance, we don't want to implant the side with the good balance,
Right?
because they're a very rare complication or side effect is that it can affect the balance function.
Right.
So we would implant the bad side. So that's why we, like you said, we would do that evaluation, and more
Exactly.
importantly in older patients who have more difficulty compensating.
Right.
Cool. Another question from Eli Bress is, looks like it's about SCCD, and what's your preferred treatment for SCCD via MCF or transmastoid approach?
Mhm.
Canal plugging or resurfacing?
I'm sorry, I had to laugh all these initials. You better explain what those mean.
So, Eli's referring to the superior canal dehiscence syndrome, or sometimes superior semicircular canal dehiscence.
That's one of the balance canals.
Exactly, it's one of the balance canals in the ear, and when the balance canal is uncovered, patients will have symptoms like they can hear themselves talk. They can even, sometimes they say that we hear our eyeballs moving, and I think
And some sounds can cause them to feel dizzy.
Exactly. The specific choice of how to repair, I think, depends on the surgeon. When I do it, I like to plug the semicircular canal, and then I will often place also a piece of fascia over it. So the fascia is like the lining of the muscle on the side of the head. And I do these in conjunction with our neurosurgeon, Dr. Lekovich, and we perform it via a middle cranial fossa approach. It's just my personal opinion, but I think that gives us a great view of where the dehiscence is, where to put the material that we need to plug the canal, and then resurface the canal. And I think the access is a lot better than if we do it from a transmastoid approach.
Yeah, very, very much. Well, it's, for the middle fossa, for those who don't understand it, we go in above here,
That's right.
take a little piece of bone out, and then go down to where the canal is, and then we're able to get direct access.
Mhm.
Of course, you know that again, another development here at the House Clinic, or House Hair Institute, was the actual approach to work out that approach where we can come in from above.
Yeah, the middle fossa approach, that's right.
Yeah.
But
Many years ago, by the way.
I would say
Even
the
before me.
the transmastoid approach actually works for many patients, and I think there are some great doctors out there that do a great job with the transmastoid approach too. And I think either would be able to solve the problem, even though I feel that at the House Clinic we almost perform more middle fossa approaches than transmastoid.
Well, I've never done the I've only done the middle fossa. Have you done the transmastoid?
I've done them, yeah, but
Oh, you have?
I prefer the middle fossa.
And how, so it was a well pneumatized mastoid where you can get them
Yeah.
above, because it's a little more.
Either above, or you can plug the canal directly if you're going to blue line it. So.
Yeah, but you have to find it. Okay. Very good.
Fantastic. Can we close out with one
Sure.
more question and then your final words?
Yeah.
Okay. Lucy is asking if cell phones and Wi-Fi can cause brain tumors that lead to hearing loss.
That's a controversial topic, but I think the short answer is no. So we think that those, like cell phones and Wi-Fi, are non-ionizing radiation. They're not going to induce any sort of DNA damage to your body's cells, including the cells along the hearing and balance nerves. There was a study published, many years ago. I read it when I was a med student. So, it must have been in the early 2000s, where there was some association between cell phones and vestibular schwannomas. But I don't think the link has really been established. In fact, I think the link is spurious. I don't think there's an association,
No.
personally.
It's like I would like to say, that we find that our patients who have acoustic neuromas, many of them have eaten tomatoes. So tomatoes,
Better avoid those.
obviously tomatoes don't cause acoustic neuromas, and so that's why
That's what you
a
say.
lot of people who have acoustic neuromas use cell phones. Does that mean that cell phones cause it? No, it doesn't.
Yeah, no. So I think cell phones and Wi-Fi are safe in that regard.
You know,
And there are other things to worry about. I mean, there are many things around us that are potentially carcinogenic. We talk about radon, that's sometimes underappreciated in basements. We can be exposed to all these things without really knowing. But specifically Wi-Fi and cell phones, no. We don't think that that causes enough radiation to cause the DNA in our cells to go awry and the tumors to develop.
well, you know, when electricity first started coming into houses and places, I saw a sign at a hotel. It was an old sign that said electric lights don't cause cancer. So,
I thought you were joking. When was that?
well, that was the hotel was at the in Pasadena, and the sign was dating back to the late 1800s.
Oh, wow.
Because there was that rumor that, you know, well, if you stay in a hotel room with electrical, you know, you're going to have a problem. Well, it hasn't worked out that way, fortunately. Anything else?
Well, there is actually one more, if you don't mind. It
Sure.
looks like it's about cholesteatoma. Do you have any good recommendations for information about cholesteatoma, what it is, what a patient might experience after surgery, and possible reoccurrence?
Yeah.
Yeah.
I think that depends so much on where the cholesteatoma is and how big it is.
Well,
Some
first of all,
cholesteatomas-
let's say what a
Sure.
cholesteatoma is.
Yeah, go
What
ahead.
is it?
So it's a skin cyst inside the eardrum. We think it arises because the eardrum is covered by skin, and then sometimes the eardrum gets so sucked in or retracted that it sucks into the body of the drum. You imagine the middle ear, which is the body of the drum, is like this. The eardrum is on top of it. Sometimes the eardrum will get so sucked in that it's in the body of the drum, and then that skin just stays in there and keeps on shedding dead skin cells. And that turns into a little ball
and it-
of dead skin cells, and that's a
and
cholesteatoma.
they can get trapped up toward the mastoid, because part of the eardrum has the weak part, the
Mhm.
pars flaccida, and that's the one that can most likely retract in. And as it retracts, the skin is produced, like you said, and it doesn't get out, so
Right.
it just keeps building up. And as it builds up, it keeps expanding and can then go into and cause issues. So that
Right.
has to be removed surgically,
Yes.
and the recurrence rate is.
Well, I don't know if I'd
Low, but-
pin it. Yeah, I don't know if I'd pin a specific number on it, but
Well,
patients with cholesteatomas typically undergo multiple surgeries. The most common number of surgeries is 2. And I say 2 because at the first surgery, we take out all of the cholesteatoma, we get it as clean as we can, and then 6 to 12 months later, we typically have to rebuild the hearing bones. And at that second surgery, 6 to 12 months later, we're looking to see if there's any recurrence, any cholesteatoma that's grown back. If there is, we take it out then, and then, like I said, we repair the hearing bones at that time. Or in certain very rare cases, the cholesteatoma at the second surgery is still really extensive, and then we have to do another one after that.
it's
So-
very frustrating when those happen.
Yes.
Fortunately, that's rare, but
Right. And then so regarding what a patient might expect after surgery depends on how big the cholesteatoma is. Most cholesteatomas actually have already eaten away the hearing bones. So a patient typically has worse hearing after the cholesteatoma is removed, almost because the cholesteatoma initially is vibrating with the remaining hearing bones. Sometimes patients are dizzy after surgery because the cholesteatoma can eat away at the balance canals. Unfortunately, that's not as uncommon as we might think. And otherwise, I think everything that goes with ear surgery, like a little bit of soreness, a little bit of headache, tightness behind the ear, pain around the incision, those could all be expected, things to happen after having had the surgery.
and we usually quote maybe the 2% chance that a patient would have a significant nerve type hearing loss, especially if the cholesteatoma has invaded into the inner ear.
Right, such as the balance canal.
And sometimes patients present with vertigo.
Yep.
And it turns out you start working them up and you find out they have a cholesteatoma that has finally eroded into their inner ear. So it's not something you want to ignore.
Right.
I do have one viewer who's been very patient with his questions,
Sure.
so sorry. Well, last one for sure, and then we'll let you all get back to work. It looks like he has a child with cochlear otosclerosis. It's a 12-year-old boy, and he's wondering what are the causes of otosclerosis at this early age.
Whoa. That's very unusual.
Yeah.
Otosclerosis is a hereditary change in the bone around the inner ear, and it's the change that only occurs in the ear. The most common effect of it is what we call a conductive hearing loss, because the stapes stirrup, the third little ear bone, becomes fixed, so it doesn't vibrate. And that's in those cases we can operate, remove that part of that bone, and replace it with a prosthesis, and that's highly successful in restoring hearing.
Right.
Cochlear otosclerosis is when that change in bone goes into the inner ear, and we typically feel that it doesn't start until the 20s and up into the 30s age group.
Mm-hmm.
More common, 2 out of 3 women, opposed to men.
Mm-hmm.
More than 50% have a positive family history. Having said that, what's the youngest patient you've had with otosclerosis?
A teenager.
My youngest is 8.
Wow.
I did a stapedectomy on an 8-year-old with a very strong family history,
Mm-hmm.
and I couldn't believe it,
Wow.
but it was otosclerosis.
So regarding the potential causes for that patient, I think it's important to rule out any metabolic issues, and that's something to discuss with the pediatrician, as well as perhaps a specialized team at a pediatric hospital, because it is very unusual to have cochlear otosclerosis at age 12. It brings to mind the
Yeah.
possibility of some disorder of bone metabolism, which I'm not familiar with all of them, but those are things that should be investigated by hopefully a team of specialists.
I think of like Paget's disease would be
Yeah.
one,
Exactly.
and
Not in that age group. So,
osteogenesis imperfecta.
that's right.
Those are things that can cause changes.
Yeah, but osteogenesis imperfecta, to my knowledge, isn't associated with cochlear otosclerosis, but
No,
Yeah.
I'm thinking that it may not be the
right,
diagnosis may be
right,
something else. It just looks like it.
right. So I think that would be my recommendation to that viewer in particular, to make sure that the child is evaluated by a multidisciplinary team at a pediatric center.
Thank you both so much for your time and your just huge knowledge on all these issues. And I think it's really helped a lot of patients. Really appreciate it.
Thanks.
Well,
Thanks for having
it's
us.
been a pleasure. We certainly do. At the clinic, the House Clinic, we really appreciate the support of the House Foundation in supporting our research and helping many of our patients too.
Yeah.
And of course, we appreciate many of our grateful patients who are our supporters of our institute.
Yes. So please feel free to reach out to us. We have a variety of social media outlets. I have my own social media outlet too, so feel free to reach out to us directly, indirectly give us a call if we can be of assistance.
Thank you.
We're out. Thank you both.